So, can you be 100% sure that this is not a melanoma or it's not a malignant transformation of melanocytoma? We can't be 100% sure about it, but I would say that because there is no real evidence of deep optic nerve extension as best you can tell on imaging, then this is a melanocytoma. It's very difficult to image this part of the eye. You can do ultrasound, but still you can't really see the connection of the nerve and the sclera very well. In the past, and we published some of those cases, sorry, some of the cases in the past, and we have done MRI using T7, Tesla 7 imaging. And that is T7. Normal, we use MRI is T 1.5, that is magnetic power of 1.5 Tesla or 3.0 Tesla. And higher the magnification, greater is the resolution. So we imaged a patient like this and some others with Tesla 7 magnet, which is experimental. It takes many hours to do the imaging. That's a problem. It's just a long time. So there's motion artifacts and whatnot. But one can see much better the optic nerve and the junction with these higher powerful magnetic MRI images. So the growth, well, how do you account for the growth? Well, I think of all the benign tumors that are pigmented, melanocytoma is the only one that can grow and still be benign, and we have seen such cases, and Alex has been working on them with Jen on iris tumors or anterior uveal tumors that are benign. We have clear photographs to show they're growing, and when we excise them, pathology, melanocytoma. So we know melanocytoma can have a relatively faster growth than a traditional nevus would be, but they are still benign. That's my general comment. Maybe Melina can add something and Alex can add something.
Yes, perfect.
I think it's a great case for you to show, Cecilia, in a grand round like this and for all ophthalmologists, because I usually get some pictures of this kind of tumor from general ophthalmologists really concerned about melanoma. And even some patients have already been oriented and informed about a melanoma diagnosis, and the patient is really worried and really sad and really desperate. And it's really important to show people about melanocytoma, that's not so usual tumors, and it's really important for them to get to know and to get is a differential diagnosis, and especially to show how easy you can make at least some differentiation between both of them using the ultrasound. The ultrasound imaging, it's really different from both tumors. So ultrasound you usually have in many clinics. It's not so difficult to find, and it's a way that people can use to differentiate it and to talk better to the patient, and always consult, of course, an ocular oncologist as well, but not to worry patients so much by the beginning of the case. So it's a great case.
So also in general, melanoma invading the optic nerve is rare, and usually, but if that were to happen, the choroidal component is really large. So it's this big sized tumor with some extension into the optic nerve. Here, the tumor itself is what, 2 millimeters, right? If you think about it, maybe 3 millimeters, and half of it is in the optic nerve. This isn't a typical appearance of a 3 millimeter melanoma that's by the disc. This may happen in a tumor that may be 15 millimeters for melanoma to get into that situation. It's very rare for a 3 millimeter choroidal melanoma to invade the optic nerve. Second, a 3 millimeter melanoma will not extend into the retina. This tumor is extending into the retina. One can see that it's obscuring the vessels here. A 3 millimeter melanoma will not have breakthrough Brooks membrane. A 3 millimeter melanoma will not have retinal invasion. So these are the things that one can easily tell them to differentiate between nevus from melanocytoma from melanoma.
I think also something very important in this case is that the patient is 20/20 vision all along. So I think if we had a melanoma with optic disc invasion, she would have loss of visual acuity, and she's 20/20 vision. So I think this is also something very important for all residents.
So there are
everybody that's here connected to think about.
So there are 2 or 3 important complications that can give rise to vision loss with melanocytoma. And so one would be a neovascular membrane. So melanocytoma being a chronic tumor that's disrupting the Brooks and whatnot can induce a neovascular membrane. And we have seen such patients that causing exudation in the macula. So that's one reason you can have melanocytoma with reduced vision. Second, we also know melanocytoma undergo acute necrosis. For whatever reason, they undergo necrotic changes with inflammation. That can give rise to optic neuritis-like appearance. And you give them steroids, the tumor will shrink, the optic disc edema goes away. So we have published a case like that too. And the third thing, and it's rare, you can have some capillary hemorrhages or some other leakage between around and the subretinal space that can affect vision. So vision is normally normal in melanocytoma, but there are specific situations when it can be reduced without malignant transformation.
Alex, do you want to say something, or we can go to the next case? I think Marcela can already take your presentation out and can.
Very good job, Marcela.
She's a good one, Dr. Singh. So.
Thank you, Dr. Singh.
You're very welcome.
I found it. Okay, now.
Okay, so Dr. Singh, if you want to introduce the next one.
Yeah, so our presentation from Cola Institute Cleveland Clinic is by Alex Melendez Moreno. Is from Puerto Rico. And he is now matched into ophthalmology residency, starting that back in San Juan. And he spent a year doing research and learning the clinical aspects of oncology. He's going to present an interesting, unique case of an iris tumor. Alex.
All right, thank you very much. Let me just share my screen here. Okay, so hi everybody. Pleasure to be here tonight. We'll be doing a quick case in an iris nevus lesion on the left eye. So a quick history of present illness. This is a 59-year-old male that presents to the clinic with an iris nevus in the left eye. It wasn't previously detected by his optometrist, and the patient had no recollection of the iris lesion in the past. Past history is it's unremarkable. No ocular history of disease, only seen for glasses, and the only family history is just heart problems, hypertension, no history of cancers. On base exam, visual acuity is normal and intraocular pressures are normal in this patient. Here we have a slit lamp photograph of the left eye. Here we can see a melanotic tumor at 8 o'clock causing correctopia and ectropia in UVI. We can also see some intrinsic vessels in the iris lesion. And also at 7 o'clock, we can see what appears to be feeder vessels going towards the lesion. And it doesn't appear to be affecting the peripheral iris. The lesion measured 4x2 in base diameter and 1 in height. We did an FA to see if there were actually feeder vessels and intrinsic vessels associated with this lesion. And we see here in the early FA, we can see early hyperfluorescence compared to the rest of the iris, indicating that there is a feeder vessel going towards the iris lesion. At mid-FA, we can see the intrinsic vessels that we mentioned before. And at late FA, we can see associated leakage by the intrinsic vessels in these iris lesion. Also, we did a UVM, which shows just to show the thickness and how much of the iris stroma is involving this lesion. The differential diagnosis here, we lean more towards either nevus or melanoma, but given the clinical examination and DFA, we were leaning more towards iris melanoma, which are associated more with correctopia, ectropic uvei, but also something very important here was the intrinsic vascularity associated with this lesion. The management can be either with observation, excision, with iridectomy or biopsy of this lesion. And we discussed with the patient excision therapy, but the patient wanted to think about his options and think about it for a little while. So we followed him after 3 months. After 3 months, we didn't see any growth. Visual acuity was normal, and intraocular pressure was normal, and he did elect for excision of the iris lesion. The type of iridectomy we did is a novelty approach using a small incision. In the traditional approach, we normally used a large corneal scleral incision, which involved an incision through the limbus, about 1/4 or 1/3 of the limbus, which required several sutures to close the wound, and this could cause visual astigmatism in this patient and also could lead to wound leak. And also the prolonged recovery in this patient is a little bit longer. In our approach, which is small incision guarded hydroaspiration, it involves multiple small incisions. We can see here in the blue lines that we can use, and we use a laparoscopic approach using vitrectomy scissors to cut around the tumor and excising it this way. This works usually with small iris tumors that don't involve the angle of the iris. Here, it involves 6 steps. Like we mentioned before, corneal incisions are made to add viscoelastic, use the vitrectomy scissors, and also one important incision that is made is contralateral to the iris lesion that we want to excise. Then we do iris resection with vitrectomy scissors, and we cut 1 millimeter away from the iris lesion, and after that we cut the iris root with curved vitrectomy scissors to remove this lesion. After this, we use the guarded hydroaspiration, which is a very important step because we use viscoelastic inside the tube, and we aspirate it. We aspirate the sample inside, and that avoids the lesion contacting any structures in the eye that could lead to seeding. Then after that, we close the wound with the pupilloplasty sutures. We close the corneal scleral incisions that we make with corneal sutures, and also very important part would be the sample handling, which we put on top of filter paper, and we can extend the margins rather nicely around, so we can have a good pathology reading on these lesions. Here we have a quick video. Let me know if it's playing.
Yeah, it's perfect.
Okay, perfect. Thank you. Here we have the corneal incisions. There we're making the corneal incision contralateral to the iris lesion. We adding viscoelastic inside the anterior chamber. Then next step is the iris resection with the vitrectomy scissors. Here we cut on the sides of the iris lesion, leaving 1 millimeter of clear margins. And we do another corneal incision to add the curved vitrectomy scissors and be able to cut the remaining part that is attached to the iris near the iris angle. And there we see that the lesion is removed. Next would be the aspiration. There's another patient, but here it's more clear. We had the tube inside the anterior chamber, and then we aspirate slowly until it goes into the tube, and then the tube is removed without the lesion touching any of the structures of the eye. After this, we just close close the wound in the iris with pupilloplasty, as shown here. Very beautiful surgery. And pathology actually showed malignant melanoma of mixed cell type with clear margins all around, and melanocytic proliferation involving full thickness of the iris. At 1 week post-op, we saw that his visual acuity was doing very well at 20/25 on that eye and 24 in intraocular pressure. Here we can see the photo of that 1 week post-op where we see the pupilloplasty sutures that were done and also the corneal sutures to close the wounds. At 1 month follow-up, we did a corneal topography to measure how much astigmatism this patient developed after the procedure. And we saw that he had minimal astigmatism of 0.37 diopters and no minimal change in the patient's refraction. Here's a 3-year post-op showing the left eye. You can barely notice he had surgery in that eye, which has very good cosmesis and a very good outcome. And Dr. Singh has actually done this in 22 patients, and he has published this before, but right now he has around 56 cases done already. And the patients that we use in this type of procedures are small lesions that are circumscribed and not involving the angle with a minimum of 2 millimeters from the iris angle to the lesion, the iris lesion in question. This eliminated the need of a large corneal scleral wound, which usually could be the outcomes of that surgery can lead to wound leak, hypotonia, hyphema. And in this 22 cases, we saw that there was no hyphema, no wound leak with any patients. Patients recovered rather well, their visual acuity, and corneal astigmatism that could be associated with corneal sutures was minimal in these patients. And also a very important part of this type of surgery is the guarded hydroaspiration itself, which minimizes the risk of tumor seeding, and also that you can handle the tumor sample rather better with minimal artifacts and handling. So I would like to thank Dr. Singh, Dr. Cavalcanti, and Dr. Singaravelu for this opportunity, and thank you so much.
That was great, Alex. It's a very beautiful case. I think it's a very nice approach, and you see a very nicely done surgery. Here, I think most of our patients, when they arrive already, maybe the lesions are like bigger than that one, and I think it makes it hard for us to try that approach, or maybe we don't see patients like that. I think I have like one patient that we're following up an iris lesion that she had already, but it doesn't show any growth, so we just keep on observing. So I don't know if you have anything else to complement Dr. Singh, Melina.
Melina, you have anything to add?
I have a question actually. When you have the peripheral iris compromised by the lesion, what would you do? Do you still do an iridociclectomy or an iridectomy, but with larger incision, or brachytherapy?
So it depends. Let me paraphrase here. So first of all, you're driven by your clinical diagnosis. You say, I suspect melanoma here. So that's the first thing you say, okay, I think it's a melanoma, okay? That's a judgment you have to make based on the examination, angiographic studies, UBM, gonio exam, whatever. And if I think I can cut it out and be able to close the iris, then for me, I would say, iridectomy or iridocyclectomy is a reasonable approach. But if I feel that the iris gap is going to be so big that I can't close it, maybe you should not do any of this. Do a diagnostic needle biopsy and then put a plaque on it. Because people can have difficulty coping with a big iris defect, especially a young person, 40-year-old. He'll have so much photophobia, then he has to wear a contact lens. Or if it's an older person, they can't wear contact lens, then they may need an iris prosthesis and things like that. So it gets a little more complicated. So you have to make a judgment as to, are you going to leave a patient with a big defect? I don't think that's good. So we had a recent patient, an elderly lady, had cataract surgery and melanoma, and I thought I could close it. But when I go there in the surgery, I couldn't close it. It was just too big for me. So that's a little bad judgment on my part, but I couldn't close it. So now I'm left with this person with a big defect. So we talked about contact lens, we talked about this, talked about that. Because if the 1/3 of the iris is missing, it's very difficult to live with that because you're going to get a lot of glare and poor vision because of that. And not everyone can tolerate a contact lens. You're working in field or whatever, you can't wear a contact lens all the time. So I think it depends upon the defect, you have to make some judgment on that. I hope I'm clear. But if it's a peripheral one, you have to do iridocyclectomy because the root of the iris takes you to ciliary body. And if you say it's a malignant tumor, I need clear margins, you really have to do at least 1 to 2 millimeters of ciliary body excision. And for that, you cannot use this approach. So you need some clear space between the peripheral tumor and the angle to do what we just showed. But if it's beyond that, you have to do iridocyclectomy.
Great.
Also, oh, sorry, Melina. So go ahead.
No, just to say it's a great consideration. Yes, we also never had such a small melanoma and central in the iris for us to do this, but I'm looking forward to trying this technique. It's really elegant technique. Congratulations.
So, believe me, more you do and more melanomas you're going to find. I can show you, and Alex had 56, we actually counted 60 cases. And out of 60 cases, and Alex can verify that, about 15 are nevi and about 45 are melanomas, correct? Give or take, right? So we say out of 16 cases, we think they have melanoma, and 15 of them actually don't, and 45 they have. So we say 75, 25%. So we are clinically able to make a reasonable diagnosis and come out correct about 75% of the time. In 1/4 of the cases, you will think it's melanoma, but it will present as a nevus in pathology or a borderline something or melanocytoma. Okay?
That's
so not everything you clinically think is melanoma will be. It's never not is. We get about 75% right. Alex, am I correct with these numbers?
Yes, you're correct.
Okay, so 40, about from 60, about 15, 1 or 2 up or down, are benign. And we thought they were malignant. There was a young girl, a growing tumor, all the things. And pathology is nevus.
Very interesting. These 15 cases of nevi or benignant lesions, did they have leakage on the fluorescent, the angel, or other characteristics that?
So we are still learning from all of it, and these are very interesting questions that you ask. Now we've gone back and looked at the angiogram, and Alex is working on it, and we have paper submitted today. I think, Jan, where are you? Submitted the paper today on the angiographic patterns of iris tumors, and she can talk about that before her talk, but we have done that. But this is a process. This is a 20-year process, right? You don't know everything the first year, you don't know everything 5 years later, but after 20 years, you become a little wise and say, yeah, maybe I shouldn't do it. But we have cases that are clearly photographically growing, and on pathology is actually a nevus. So we are surprised as every time we say growth means melanoma. Not really. Growth means melanocytoma and some nevi. Maybe it depends on the patient's age or time. I have no idea. We're starting to learn. So anyway, Jan will comment a little bit about the angiographic patterns. But there was some concern in these cases. And the other component, and which is hard to tease out, is patients' own anxiety and their own thing. Oh, remove it if you think it's melanoma. And I said, no, let's think about it. No, just take it out. There's some people who want that done, and so the patient also sometimes drives it. And it's hard to capture in the research or analysis the real indication. But still, I think we are about 75% right and 25% wrong in the clinical judgment of iris melanoma diagnosis. Yeah.
That's perfect. I think, Jen, you can start
Sure.
sharing your screen. I'm just gonna add something as we have a lot of residents here. Usually we only perform surgery or indicate the surgery when we have a lesion that wasn't there before. So a patient that has like a very light iris color, and then he or she complains of a lesion that started like in older age and everything. So this is a suspicious lesion, and you should probably maybe do as how do you say, a fine needle biopsy, diagnostic biopsy, as Dr. Singh said, or maybe perform this kind of surgery if you have, if you can do it, if you have someone like Dr. Singh to do it. And also in patients that has a lesion that is showing growth, that's why Dr. Singh said that some of them that were growing were nevi or melanocytoma, but usually it gives us an idea that something maybe is going wrong. So we also indicate surgery in those kind of cases.
So I just wanted to make a comment. I'm Jan. I'm the ophthalmic oncology fellow, the clinical fellow at the Cleveland Clinical Eye Institute, working with Dr. Singh. With regards to the fluorescein angiography study, a few of the main findings. So we looked at the presence of intrinsic vessels, feeder vessels, leakage, and also angiographic silence, meaning absence of all findings. And we see that angiographic silence is associated with nevi. It's only seen in iris nevi. Feeder vessels are more associated with iris melanoma, and intrinsic vessels are also associated with iris melanoma. So
this is a statistical significant difference, right, Jan?
Yes, yeah, it is.
And just tell them how many nevi and how many melanomas did you have in this study, just so that they'll know the numbers.
About 40 melanomas and 15 nevi.
And they're all most of the all melanomas are biopsy proven.
Exactly.
And nevi were
a few were biopsy proven, and the remaining were clinically stable.
Okay, so all melanomas that we included in the study were biopsy proven. So that's also important to know. Okay, all right, we can start to your case now.
Great. Are you able to see my slides?
Yes.
Okay. So the title of my presentation is I Have a Bone to Pick. So our presentation is of a 15-year-old asymptomatic female who was referred for evaluation of a fundus lesion in her left eye, noted during annual eye exam. In terms of her history, nothing remarkable. She wears contact lenses for mild myopia, otherwise denies a family history of malignancy or ocular tumors, and as well as a personal history. So in terms of her base exam, we see that she has 20/20 vision in both eyes, normal intraocular pressure, and normal base exam. The anterior segment exam of both eyes is normal, as is the fundus exam in the right eye. So when we look at the fundus exam of the left eye, this is what we see. So here's a color fundus photograph, and we see that there's a juxtapapillary lesion that's yellow-orange in color with sharp margins and a scalloped border.
Okay,
so next,
stop there. Okay, Marcella, that's the only name I have now. I don't know the other residents. So Marcella, the one who presented, what do you think this is?
Let me go back to the picture.
Marcella, are you still there?
Yes, I am, Dr. Singh. I'm
What do you
here.
think?
I actually thought of a lesion that seems like a bone structure in the choroid, but I'm sorry, I don't remember the name. Como é, Cecilia? I don't know it in English, but I've seen one patient in our with Dr. Cecilia Cavalcanti at Altino Ventura Foundation. And it's very similar, but it was bigger and also near the optic disc. I don't know the name in English. I'm sorry.
Okay. No, you're absolutely right. Okay. So we continue, but you're right. You have to be very proud of it.
Thank you.
So this is a unilateral juxtapapillary yellow-orange choroidal lesion. And like you said, Marcella, choroidal osteoma is highest on our differential. Other things include choroidal hemangioma, amelanotic nevus, amelanotic melanoma, and other entities as well. So we investigated this further by getting an ultrasound. And what we see here on the B scan is this hyperreflective choroidal lesion, and it has this interesting pattern of a shadowing pseudo-optic nerve artifact. When we look at the A scan, we see that there's high surface reflectivity with sound attenuation. And when we look at the OCT, we see that here the choroid is replaced by this, different tissue, and the foveal scan looks normal. So ICG angiography is a really important test in this case. So at the location of the lesion, we see that there's hypocyanescence. This allows us to differentiate this lesion from a choroidal hemangioma, which would actually show hypercyanescence. On fluorescein angiography, this is a non-specific pattern, but we see early leakage with late staining. And so going back to our differential diagnosis, took us a little longer than Marcella, but we're left with choroidal osteoma as our diagnosis. So what ended up happening to our patient? So when she presented, she had 20/20 vision. The lesion measured 3.5 by 3.5 by 1 millimeter. When we saw her back 9 months later, we see that the lesion has grown both along the superior border as well as temporally towards the fovea, and now measures 4 by 4 by 1. And at that time, after that, we actually treated her with PDT, so photodynamic therapy at full fluence. And saw her back at the 2-year mark. And we see that her vision is 20/20, but the lesion continues to grow, most importantly, towards the fovea.
Okay, stop there. Stop there. So, anybody with some bright ideas? What are we going to do? It's growing for sure. The diagnosis, I think, is correct. And the PDT hasn't worked. So, tell me what I'm going to do.
We pray.
Pray. Okay. Marlena, what do you think?
I think Marcella is amazing. So maybe she could answer it as well. Poor Marcella. No.
We are entering a territory where we actually don't know the answers. Let's be honest. Nobody knows the answer.
Yes.
Marcella wouldn't know, and Marlena doesn't know, and I don't know either. So nobody knows the answer. We are entering a very unknown area of complication here, the growing tumor of osteoma. Yeah, carry on.
So we decided to repeat the PDT treatment, and we saw her back about 6 months later. And yet again, after the second PDT, the lesion continues to grow even closer towards the fovea. So at this point, we decided, well, maybe third time's the charm. Let's do it one more time. So we repeated the PDT again. And now we see that the lesion has even more continued to grow and is now towards the fovea at the edge of it. And there's actually a choroidal neovascular membrane associated with this. So what do we do?
So
and here's just a closer picture.
So you have done something that doesn't work 3 times over. A prayer doesn't work and your treatment doesn't work. Okay, there we go.
So here in this image, we can see that it's really encroaching on the fovea. Now you have some intraretinal fluid as well associated with it. So for this patient, for the CNVM, we decided to treat her with intravitreal Avastin, 3 injections. And in terms of her treatment for the growth, we decided to treat her with proton beam radiotherapy. So our patient was treated at Mass Eye and Ear. She received 20 grays of radiation in 4 fractions. And we see that about 7 months after her proton beam therapy, the lesion has finally stopped growing. And we can see that here in the image on the right. And looking at the OCT, the foveal contour is now more normal, and the lesion itself starts to thin out. So what is a choroidal osteoma? So to give a brief overview, it's a benign ossifying tumor where mature bone replaces the choroid. It's typically in a peripapillary or papillomacular location, and it's a rare tumor that occurs in the 2nd or 3rd decade of life in young women. And it's thought to be a choristoma, but we don't really have a great idea of what the etiology is. And there are 3 main mechanisms for vision loss. So similar to like in our patient, choroidal neovascular membrane is a reason for vision loss, as is isolated subretinal fluid and growth into the fovea. So I'd like to talk about the management of these lesions. If the patient is asymptomatic, we observe them. If there's a CNVM associated with the tumor, we can treat it similar to what we would do with any other CNVM, with most commonly using intravitreal anti-VEGF injections. But what about growth? What do we do in this situation? So you can use PDT like we did. Older reports suggest laser photocoagulation, but isn't done as much now, and proton beam radiotherapy like we did with our patient. And so I'd like to share this study, which looked at a case series of 9 patients who were treated with PDT for choroidal osteomas that were threatening the foveola. And so the question is does growth really happen after PDT? And what they found was that there are 3 out of the 9 cases where there was growth after PDT. And when we look closer at who these patients were, we see that the growth after PDT occurred in younger patients who had a greater tumor thickness. In this series, they actually didn't do additional treatments for the growth and just decided to observe. However, this is a case report where proton beam radiation was used for choroidal osteomas. And clearly in the middle panel B, we see that there's growth that's threatening the fovea. And they show follow-up after the radiation therapy, the proton beam, 19 months afterwards, where they show that the lesion stops growing and the patient has good visual acuity. So some key points that I'd like to emphasize. So characteristic features of choroidal osteoma, it's a yellow-orange color, peripapillary with sharp scallop geographic borders. And the important B-scan finding is shadowing with the appearance of a pseudo-optic nerve. There's a few different reasons for vision loss, with CNVM being the most common, and growth is actually rare. And when there's growth, in terms of treatment, we have a couple of options, which includes PDT or proton beam radiation therapy. So I'd like to thank Dr. Singh and Dr. Cavalcanti for giving me this opportunity to present this interesting case. And I look forward to a really interesting discussion.
That was an amazing option for treating osteomas. And unfortunately, we don't have proton beam therapy here in Brazil. And we have difficulties in finding the vetapofferin for the PDT as well. So we are a little bit limited in treating these osteomas.
So you're absolutely right. We also don't have proton in actually Cleveland. But if you look at how could you treat this with radiation, you say, oh, we can do a plaque or other things.
I was gonna ask you this. If you think about brachytherapy, if you don't have access to.
So if you look at the dosimetry, right? So if you put a plaque there in that region, and we treat melanomas like that around the nerve and even some retinoblastomas. So with the plaque, every tissue will get 20. Gray is the apex, and everything else will get higher than 20. So the optic nerve may get 50 or 60, and the RPE in the macula may get 60, 50 gray. because to get 20, 25 gray to the apex, you have to give much more at the bottom, right? So there's a gradient. And the base is typically 3 times more, or at least 2 times more than what is on the apex. So you are radiating this young person's eye with 20, 25 gray to the apex of osteoma, and maybe about 40, 45 gray to the back in the macula. And that will take away the vision from radiation retinopathy. So the purpose of preserving vision, therefore, is kind of lost. But with
Yes.
proton, nothing will get more than 20 gray. Everything will get 20 gray. Optic nerve will get 20 gray, osteoma will get 20 gray, macula will get 20 gray. It's like a beam of light. And she's a 16-year-old, 17, 18-year-old now. She's 18. She came last week for follow-up again, about a year after stable. And she's a college kid. And so this is important for long-term issues. So I would say from radiation oncology, excuse me, the distribution of the doses and the risks for retinopathy, etc., proton is safer. That's what we did. And there's only one case report of this in the literature. So will be the second case. We'll be publishing it as we get more follow-up. And we have had another case also that had to have this treatment.
I think it was a great case and a great approach, Dr. Singh. I was going to say, I don't know what else to do. But that was.
So you have to stop and think. And so osteoma resembles hemangioma to some extent. It's a vascular tumor, and the PDT is good treatment for hemangioma, and we use that for osteoma. We also know that hemangiomas also respond to proton. So you're treating this osteoma like you would treat a hemangioma if you did not have the PDT, for example. So that's kind of what the derivation is. And it makes perfect sense. It makes perfect sense, both from the pathology of the disease is growing, so it's for growth. CNV, and very interestingly, once we stopped the growth, the CNV also went away. So when the osteoma is growing, obviously it is making its own blood vessels, it's bone that's growing. Maybe all those angiogenic factors also disappear. Once you treat the bone, it stops growing. You don't have no CNV. I mean, she may get more in the future, but for now, at least a year follow-up, it seems to be no growth, which is very, very impressive. I think that's very nice. Jan, you did a great job. So I have to tell, so Jan is our fellow, and she's going to be graduating in June. She just got married last year. She's graduating this June. And now she's going to go into retina. I don't know why she wants to do that, but that's what she wants to do. But that's okay. So she's going to go to Washington, D.C. to do a retina fellowship, which is a good way to make a living. So I understand that.
That's great, Jen. Congratulations.
Okay.
Thank you.
We have a few more minutes, Cecilia, if you want to say something.
Yeah, I'm gonna share my case just to make you guys a little curious about it. I'll try to be very fast, as we have about 10 minutes. So let me share this. Is this working out? Is everybody seeing my screen? Okay. So then I have
Yeah, it's not on presenter's mode.
Really? Again? Okay, hold on. Let me try again.
Na verdade, dá para ver o próximo slide agora, sabe?
Deixa eu tentar aqui, Vini.
Ainda não. Not yet.
E agora? Nada?
Não, tá no modo que você consegue ver o próximo slide, sabe?
Let me try again and again. I don't know. I already tried this today.
Yes.
Anyway, okay, hold on. Now I already took it off.
Oh my.
Yeah, it happens. Is it working now?
Yes.
Okay, hold on. Let me just. let me just change my screen here. Okay, so this is a case of a 56-year-old male. This patient is a priest. I already asked him about a lot of his life, but because he was sent for evaluation because he was complaining of an itchy eye, and his best corrected visual acuity was 20/20 in both eyes, and he had an unremarkable biomicroscopy except for this. So because of he had an itchy eye, I was looking maybe for I don't know, maybe an allergic conjunctivitis or something. And when I everted it, I could see this lesion. And here I think we could see in a little zoom.
We can't see your next slide.
Oh, again?
Yeah,
It
the
did
slides
that.
are not changing. Yeah.
Okay. I don't know what's going on.
No, it's okay. Just
It's okay now?
No.
So it still doesn't pass.
close it, unshare it. and reshare it.
I was trying to be fast, and now it's gonna. Okay, hold on. I'm gonna try one more time. Otherwise, I'm gonna stop.
Yes. Yes.
Share again. Yeah.
Have a little faith. It's gonna work.
Yeah.
Passou agora.
Now, yes, yes, yes.
Yeah. Okay, so we can see this lesion. It has a lot of vessels, and we can see this white dots in it, which was weird. And we could see nothing that was really close to an allergic conjunctivitis or something like that. So I was thinking I already had some patients like this before, and I was asking him if he worked maybe with agriculture, maybe with some plants or something, because I was already thinking maybe about something that was due to an infection, and he denied everything. So first thing, we need to know that it's a conjunctival lesion. We can have neoplastic lesions or no neoplastic lesions. So I was thinking, what is this? Maybe it's not a tumor, and maybe it's something else. So as I have somebody to help me, like my brother, I asked for a confocal microscopy because we had a few cases before, and confocal microscopy helped us to see if maybe this was an infection or maybe this was really a tumor or something else. And here in the confocal microscopy, when we compare to the clinical picture of the patient, we can see that we have this round areas here in the blue arrows that had also a membrane. So it was kind of like an encapsulated thing with a hyper intense center, which we could compare to the clinical picture and see that maybe it was compared to these white dots that we're seeing. And also we had a large number of inflammatory cells around this round structures, and we could see that it had a lot of inflammation. And also what was interesting that they had this hiphas, so we suspected of a fungal lesion also. So now this patient is maybe not a tumor, maybe something caused by a fungus that we don't know which one it is. So one thing that I had to point it out today, that not all conjunctival lesions are tumors. So we need to see about infections, and we know that a lot of infections also can cause some tumors. So we need to rule out what's going on and ask the patient what he's doing and if he had any correlation to what you think. So also we had some cases a few years ago that the patient had a lesion with a lot of small white dots, and we performed a biopsy, and it was another kind of fungus. It was a adiaspiromycosis, which I never heard about until this patient came. So we had 2 cases of this, and in the same year, actually in the same week, I don't know what happened, and both were working in agriculture. So we know that that's contamination by soil and plants and things like that, which did not help us with this patient that we're dealing right now. And also we had a case of a teenager. We had this also similar lesion with this little white dots. And we did also a confocal microscopy, which is different from the one that we're seeing. Here we could see that we have a lot of small white dots in the center of the lesion. And we could see that there were spores and also hiphas. So this was rhinosporidiosis. It was confirmed by also a biopsy. And Melina and Lydia also talked to me about this case this week that was also rhinosporidiosis that was from São Paulo. So these lesions, maybe we don't see them as often, but we need always keep an eye and think about it. And so what is this? We still don't know. So I was just gonna bring this to you so we could think outside of the box. So we're gonna find out what this is in the next episode because this patient did not come back yet. So we're talking to a lot of people trying to figure out what this could be by the confocal microscopy. Maybe, I don't know if we're gonna be able to excise it, or maybe we're gonna try empirical treatment. We don't know yet. So I just brought this case to make everybody curious about it.
So, Cecilia, it's a very good case. I would excise it because you need good pathology, and then you can publish this case.
Yeah, I knew you were gonna say that, Dr. Singh.
Because
Please excise it.
yeah, please excise it, because then you, first of all, that will take care of the infection, because we don't have good antifungals, for the eye drops. What antifungals do we have? Very little. So it won't get there necessarily. It's under the lid, he puts it, it goes in the inferior fornix and comes out. So even if you can find a drop that works against this fungus, which is very unlikely, you don't know what fungus it is, so you don't know which one to use. So I would excise this area, send that for biopsy, confirm it, and you say, in the future, if you cases like this is the fungus. So right now you're still exploring. So I think a pathology would really be very, very interesting. And plus we have no treatments really. I mean, we don't have good antifungals that you can use. We don't know what fungus it is and what will work for him. You can get corneal toxicity, it's 20/20 vision. Next, you'll have something wrong with his cornea because of your drops. So you are in more trouble. And surgery will be very simple. Put a Calesian clamp, just like a Calesian, use a little punch, maybe 5 millimeter punch. You can take a little tarsoconjunctival excision and suture, nothing, it will heal. That would be the answer. That would be the way to go.
Yeah,
Anyway.
I'm waiting for him to come back.
Well,
So,
where he works. He's a priest. He can't be very far. There are so many churches in Recife. Just find him.
Yes,
Get him
bring
back.
him back.
The difficulty is he's from another state, but he's gonna come back.
He's going to come back.
Yeah.
All right. Okay. Well, you pray for it. Okay.
Yeah. So it was very nice to have everybody here, and I hope you all enjoyed it. As we are at 9 p.m. here in Brazil sharp, we did 1 hour webinar here with all these incredible cases and all these incredible people. So thanks, Marcela. Thanks, Jen. Thanks, Alex. Thanks, Dr. Singh, and thanks, Melina, for everything. And I hope we could do this again soon. And we keep in touch and we keep sharing our difficult cases.
Yes.
And
Thank you
hope
so
you
much
all
for good
enjoyed
work that you do. And thank you for inviting us all. It's been a privilege.
The next
Very
time,
good to
Dr.
see you.
Singh, you need to come in person so you can eat some fish.
And lamb.
Yes,
And lamb.
I remember.
Okay. All right. Thanks, everybody. It's been lovely. Okay.
Thank
Bye.
you, everybody.
Thank you so much.
Bye-bye.
Take care.
Everybody,
Have a good night.
night.
Bye-bye.
Bye.